Welcome to the After Hours Clinic with Dr. David Vicarious and Better Life co-founder Andrew Lane, where we unpack the science of health and wellness, cut through the noise, and add a healthy dose of humor. Dr. Dave, welcome back to another Better Life After Hours Clinic podcast here. We have an exciting guest today. We've got our first guest. It's quite exciting.
It's great to be back, and it will be great to mansplain who our next guest is. This is our first guest, so for all you listening, I am super nervous, but super excited. So I'm going to give a little introduction, and I'll allow our guest to really introduce herself, but I'll just give a little background as to why who she is and why we're bringing her here today. So our guest today is Elle Miller. She's a licensed therapist who specializes in PTSD and trauma and works with first responders. I got the idea to bring her on because on my personal YouTube channel, I very recently released an episode that talked about an article that looked at the therapeutic use of bath salts for the treatment of PTSD. Now, for those of you who don't remember, in around 2010, bath salts were all the rage. This was like a psychedelic people were getting from head shops and smoke shops, and they were going nuts and biting people's faces off. It was like the terror, it was like the kind of cultural terror at the moment. But this trial actually showed some significant benefits, at least in a small population over a short period of time, in using this kind of illicit drug to treat PTSD. So it to me brought in the question of moral hazard, right? If there is, something that's potentially a drug of abuse for a condition, are we going to see like this glut of overdiagnosis of PTSD? Just kind of like people have talked about ADHD with, stimulant usage. So I wanted to bring in an expert to talk about this topic. I hope I haven't talked too much. Uh, Elle, let me turn it over to you. Just tell us a little about yourself.
No, that was a good intro. So I have been a licensed mental health clinician for 16 years. I started in recidivism reduction programs in King County in Washington, focused on people coming out of prison, getting reestablished on the back in society in the direction they would like to go. Then I moved down into community mental health, focused on trauma, which landed me in children's sexual assault, working with children who were sexually abused as well as their family, which is vicarious trauma and secondary trauma. And eventually that progressed into my own private practice where I focused solely on trauma in general. And from community mental health, it was a lot of women and children. And then it progressed in my own private practice, it landed with military and trauma, which then progressed into first responders and medical professionals. So people who have really high stress jobs and the impact of PTSD can have on them in their lives.
As I hear this, it sounds like you gravitate to really like heavy topics in mental health, right? These are like, what do you think made you kind of interested in these areas?
Seeing a need and having capacity, and then following where I just had an abundance of interest, truthfully. And what landed, especially capacity changed from children's sexual assault when I actually had my own children. I had less capacity. So I'm really glad I did that, and also recognized that it wasn't a space I could continue while also becoming a parent on my own. It just became a little too challenging, but I'm still really glad I did it. And then seeing a huge need with medical professionals and first responders and military, it became a really easy avenue for me to focus on because so much stigma pulls people away from seeking help. And if you imagine the people who need it the most, people who tend to help others don't receive their own help. And my hope was to do what I can to help bridge that gap.
Couple of things in there very interesting. One, I I just have to ask, when you say you ran out of capacity, tell me what you meant by that.
When you can have an objective approach and your personal life doesn't interfere with the viewpoint you're having to offer the best care, and having a good, um, you know, humility, ego check, whatever it is, to recognize that if that is skewed by your own role in your own personal life gets in the way, it's a good time to take some reflection and see if this is still the direction you want to go in.
So I realize this may not be the conversation you want to have for the next 30 minutes, but for the next 30 seconds, I should clarify. It sounds like your answer really says that, like, hey, becoming a parent and focusing on children at home gave you less capacity professionally to do the role. Um, that surprised me because I thought your answer was going to say doing the work professionally really reduced my capacity to be a parent. You did that wasn't the case.
No, no, it's the opposite. I became it's just more subjective, and then more, um, especially working with children's sexual abuse, I would do reunifications even between like, um, so children who had abused each other, siblings and families sexually, and helping those reunifications as well. And if you don't have the bandwidth to not to have biases, right? Like, you don't want to be biased when you're holding space for healing, for recovery, for moving forward. You don't want to hold yourself. We all have biases, but you really want to make sure that those are checked. And countertransference gets really in the way of doing really successful mental health care. So I just started not being able to fully be present now that I had a experience on the other side.
Wow. That is happy. So do you think that, like, maybe, for example, in those reunifications, you would have been less uh, willing to allow for it because you were sensitive to, like, what if this was my kid and I'm putting them in harm's way? And maybe that would make you overly conservative, that kind of thing?
Somewhat, yes. Yes. And more like how this happened, and now that I'm a parent, how could, right? Like, my own questioning, even though I knew all the answers, it just became more emotionally engaged in a way that was about me. And any therapist saying when it's about you, it's not going to be the best care. Do I imagine I can come back now, having been a parent for a while? Probably, maybe.
It really just challenged your ability to remain objective and kind of detached from the situation and but able to professionally manage it.
At this moment, I'm going to apologize to everyone. I'm veering far off topic, but I'm going to
We're
talk.
here to talk about PTSD,
I
Dave.
know, but one of the things that we try to promote within Better Life is this idea of bringing together communities and establishing social connections. It's so important for your health. But it's funny because recently I have been kind of reaching out to my neighbors, telling, oh, bring your kids over. Like, I have small kids, they can all hang out, they can play in our, we have a large yard and all that stuff. And I
And we got candy. We got candy. We got
yeah,
toys.
we got candy, we got a van, the candy. But, like, I'm always nervous that, like, maybe my parents think I'm like this creep, and I can imagine if you were my neighbor and all day long you had been treating the victims of sexual abuse, you would probably look at me a lot differently and question my intentions. I don't Am I accurate, or
Yes, and no. So, when you're doing something in repetition so much, you become inundated in it, right? So, looking at the children, a brother and sister in line at Starbucks in front of you, instead of thinking like, "Oh, that's a cute interaction," you're like, "Oh, I wonder if X, Y, and Z is happening." And that's a self thing. That's a like, whoa, okay. That's a secondary trauma response. That's a vicarious trauma. It's changing the way I'm looking at the world. And I'm no longer able to hold space for the majority of siblings don't hurt each other. Majority of people who have good intent are good intentionally. And so if you start to imagine that everything is dangerous, your life gets really small. and you no longer are curious and no longer hold space. And I think it's a good parameters to have hypervigilance, right? To some degree, but not to the degree that you're like, well, everyone is out to hurt everyone. So I will do nothing and engage with that no one. And then you're not ever getting to right that or correct that by through your experience.
I love that you bring this up because this is something that like I kind of debate in my own mind. So like a book that I I mention a lot is Jonathan Haidt's Coddling of the American Mind. And you know, in that book, the book kind of looks at child development and how we're kind of gearing our kids to not, you know, be too coddled and not being able to deal with the real world. And one of the things he really brings up is the fact that there is perception amongst people that there is, you know, the world is a much more dangerous place than it was 20, 30 years ago. But at least according to the statistic he presented, that doesn't bear out. And it's funny that you're kind of talking about that like same kind of like bias, right? Like where you're looking at the world and looking for danger where it may not exist, and that like, you know, there's a potential harm in that, right?
Yeah, absolutely. And um, I see it a lot with first responders specifically, having such up close experiences of the worst of humanity and people treating each other so harmfully. And to hold tether to the other side, especially in your own life and wanting to protect the most precious parts of your life, your family, your friends, your children, it can feel really hard knowing and having so much experience in up close danger and horrible, uh, traumatic moments in people's lives. So it's almost becomes more crucial to spend time so that you keep that width and that broad experience of humanity in every type of person, not just the most harmful ones, and in your perspective that now that is everyone.
Which can be hard to do if you're a first responder and on top of that you're dealing with PTSD. I think I'd be curious to learn more about your patient profile. I mean, without getting into specific patients, is it a lot of law enforcement? Is it a lot of paramedics, EMTs, nurses, doctors? What do you?
I have contracts with different fire departments locally around Washington so that I am their mental health practitioner, their MHP. So Tacoma, Renton, Central Pierce, which is quite large, South Pierce. There's different departments that I work with. So a large number because of that are for firefighters, paramedics. I also see individuals who are police officers, law enforcement, and medical professionals, as people, it all translates. It doesn't that I don't need to be a first responder to work with first responders. I need to know trauma, and trauma is high stress jobs. So I see quite a large number of people, also retired first responders, and I would say right now, you know, 95% of my caseload is first responder medical professionals, um, and the rest is the general population.
What drew you to this specific population? Like what made you like how did your practice evolve to all of a sudden include like did you have a connection in a family member, a spouse, you know, was there some connection to the first responder population?
How many firefighters have you been married to?
None, none at all. Going from working with women and children and then to men because of the military aspect that I started just more and more than getting referrals. I just saw a huge need. And I was like, whoa, men are very different. And first responders is a very male dominated industry. And I started learning very quickly that there was such a lack of support for this area, profoundly. You know, being someone who can sit and listen to the experiences over and over.
Not everybody can do it.
Not everyone could do it.
It helps if you've worked with in these you've heard these depraved stories before in from other contexts too.
Because of that, there's not a lot of support, meaning if you go to a therapist and they're like, "I need to talk to you about seeing, dead people quite often in my job," and it can really blow them out of the water because that's actually not the thing. Like, I don't care how many dead people you've seen, like, that's not actually what I'm worried about is, like, the quantity, or it's the ones out of, like, 200 calls, the ones that you still replay, you can smell, you can remember these really tiny details. Those are the ones I care about, and I don't want them to get lumped in with everything else.
But I have a lot of fascination with one of the points you brought up, which is like all of a sudden you're going from women and children to a male based population. Now, one of the interesting things when I started my practice in Better Life is I now deal with a lot of women's care and actually children care as well. Um, in most traditional practices, when you're an employed physician, you don't deal a lot with that because women tend to want to go to women doctors. So it has been like an honor, a privilege, an absolute fascination to get into the world of women's health, but also very intimidating. I don't know. Did you have any of those feelings, like being a woman speaking to a large male population? Was there any nervousness, imposter syndrome? Like, did you listen to a lot of the Joe Rogan podcast to prepare to speak to these young men? Like, tell me about that.
Oh, that's such a fun question. Um, Although I am a woman, I have 2 older brothers. I have, I've always been kind of skewed to the tomboy myself personally. And going into a space where I can help a population grow and expand something that is innately given more room to women, to girls in life, just through social aspects, uh, feels like having like some really great information and just wanting to share it so much and not expecting the person who doesn't have it to somehow um not have the capacity to because society says so, or to imagine that they're judging me based on what I know and what they might not know. I think, of course, I come into spaces, I do trainings in front of large groups that are mostly, the paramilitary culture of first responders, and and fire departments, police departments, where there isn't a lot of warm connection and a lot of people who are stone faced, and it can feel hard. It can feel like you're coming up against people who are pretty much uh, believing that the stigma, right, is that mental health is not important. It's dumb. It's for the weak. It's for women, whoever, whatever it is that is kind of really essentially negative, can feel hard. And yet my job is not to convince anyone, it's to create space that says, "Hey, this is what I have to offer. If it resonates with you, let's go deeper. I can help." And I do not, and I always say this, like, I don't think everyone needs therapy, right? Like, I'm not here to like, "Hey, everyone needs therapy." I think everyone in some degree can benefit, of course, because I think we live in echo chambers of ourselves and we need people who are objective and can hold space for all of us without any uh getting something out of it themselves, right? Our friends, our family, they know us subjectively and they're getting something out of the advice they offer, the emotional connection, and having that space is really beneficial. However, I do not believe everyone needs it. So if I have some tools and I can offer and connect, awesome. If not, awesome, right? I just want to offer the opportunity for people to expand their parameters in which they know how they live, you struggle.
It's funny because as you're describing this kind of particular population of men that have been taught, or I guess it's known as toxic masculinity, to suppress feelings. You're speaking to the choir. That is the exact culture I come from. Like, if I ever went to a therapist, I certainly would not tell my family because I don't come for a culture where mental health is really recognized as a real thing. And to be honest, if I were to pick a therapist. I actually, I don't know what your take on this, Andrew. If I were to pick a therapist, I actually would want a female, because uh, my bias.
Because women are better at talking about your feelings. Yeah.
Well, the patriarchy has taught me that women are more in touch with, that side of our personalities.
I think it's also like, yeah, stereotypically easier to be vulnerable with a woman than it is with another man, right? I mean, it's um I wanted to point out like many of our colleagues, consultants, friends who are doctors also point out that just within the medical doctor community, there's a bias against ever using therapy because so many people are worried that they may be vulnerable and then have something reported that could cause them to be seen in some light as being less able to render good medical care. And so there's kind of this culture around like, don't ever put anything on the record, um, don't talk about how this is hard or that is hard. You're just at 100% all the time. Nothing ever phases you. Do you get some of that in the first responder world as well?
Oh my gosh, yes. You guys are just it's like yes, you are preaching exactly what I see all the time, and I have so much to talk about that, but I'll try to be concise.
No, I'd love the non-concise version. I'm sure there's like a disclaimer that's like, welcome to therapy. Just so you know, as long as you don't talk about hurting people or yourself, uh, don't hurt anybody, don't talk about hurting yourself or others, and everything else can be 1,000% private.
Yeah,
Is
yeah.
that
I mean,
that's part of it, right?
I am HIPAA compliant, right? Like,
Right, right.
and I am also, oh my gosh, someone who recognizes how much that mentality actually hurts people and leads them to burnout, compassion fatigue, withdrawal from their families, not just like hurt them professionally, personally. When you feel untouchable because you believe you have to be, everything that actually lands as painful, you digest and try to water down as something that should be okay, which doesn't actually dissolve it. It's not something that's not how you metabolize is by shooting on yourself or by making it small because you should be something else. It actually just stays there, and then it comes out as irritability, it comes out as withdrawal, it comes out as numbness, it comes out as lack of connection, it comes out with from, um, I'll just I'll just pull back until I get better, until I'm over this. But it doesn't work that way because you're not metabolizing it. Like feelings, every human is supposed to have the feelings. You have a whole box, the crayons. It's and no, there's not good or bad. And yet we start to imagine so quickly that um the ones that we quote unquote as society label negative are somehow are not tolerable, that they're going to stay with us forever. If you're excited about going to a concert, you're like, "Well, I can't wait. I'm gonna go to the concert." And then when you're no longer excited, you're like, "And now it's over."
You
And
get over it pretty quickly. Yeah, you buy a
yeah,
new car, you're excited, you get over it pretty
you
quickly.
have that
Yeah.
understanding, right? You're like, "I know I'm gonna feel happy, and then I know when it's over, it's gonna go away." And so you don't sit and worry like, "Oh my god, what if I'm never happy again?" Or what if I'm happy all the like, no one worries about that because they see it as a good thing.
You also don't worry about expressing those feelings, right? You don't worry about bottling those up. You can be excited about.
This makes total sense that I'm happy. I enjoy this band, right? It's an
Just don't say Taylor Swift because Dr. Dave has an ongoing vendetta with Taylor Swift.
No, no, I am traumatized by the popularity.
Traumatized.
As a lover of music,
We think he has PTSD from
yeah, when
pro.
I hear her ship in the grocery store, it's like immediate, like, cold sweats. Oh,
I'm stuck in that moment. Yeah, it hasn't been metabolized for you. So, I we have this negative interpretation that if we feel shitty, it's gonna stay. And if it's a bad feeling, it doesn't make sense for us to be like, wow, this is I'm feeling vulnerable, I'm feeling helpless, I'm feeling sad, I'm feeling embarrassed, I'm feeling whatever. We do not like that. And we don't by doing that, by not spending time in it, we don't learn that it goes away or that it's purposeful, especially when we don't talk about it and when we bottle up or we try to sell it to ourselves cognitively by watering it down. Like, oh, I'm just tired, or oh, da 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 da. I don't know if you've ever done that to yourself, but you
Or
overgeneralize.
make excuses. Yeah,
Yes.
yeah.
Yeah.
I mean, I'm guilty of most of this, right? Like I don't tend to get into the headspace of thinking that it won't go away. Like I'm pretty aware that this too will pass, but I find it really hard to when I'm processing negative emotions, a negative experience, I find it really hard to see the utility in talking about it. I find it extremely hard. I think like I don't want to be a downer. I don't want to bring others down. And then eventually my wife's like, "You must have had a really shitty day at work. Can you just take a deep breath and maybe talk about it, and then like, you can stop being irritable with everybody?"
I see this all the time, Andrew. Yeah, this is like
I'm glad I'm not alone.
yeah. Oh, no, from
This
women,
is this is good.
we have so many stories we tell ourselves about the troubles that we have, and whether it's sharing it with the people that are a witness to our life or, just articulating it, right? We don't wanna do that, like, well, if I talk about it, isn't that just me spending time in it? And the truth is, your brain needs to hear things, right? We overthink all the time the bad things. When you are actually writing, when you're talking, you're thinking as slowly as you're saying as you're writing. It slows things down. It also allows processing. I tell people like thinking about it, talking about it, writing it down are three different ways of processing. Your brain has different abilities to do that. And then you metabolize it. I don't know if you ever told someone that you're and you can think about this, right? You're like, you go out with a friend and you're like, dude, this sucked. And let me tell you, I had this worst day and this person was awful and I'm so angry, right? Like he was just the worst and it makes me so mad. I don't know if you've ever been to someone and they're like, you kind of sound a little annoyed.
You sound negative right now.
No, like, you just sound a little annoyed. Like, what's the big and that's what we do to ourselves. When you don't name the thing truly, you don't get the benefit. You try to sell yourself and someone else, and guess what happens? You don't feel heard, you don't feel connected, and that emotion stays there, and then you kind of play the riddle of like, "Oh, well," or "What is this person doesn't get me?" Or the opposite of like, "Well, something's wrong with me." The number one thing that dials down in intensity is validation. Validation is from ourselves as well, it's just naming the thing and saying, "No, this is what it really is." And if you've been to someone who's like, "Hey, I'm really angry," and they're like, "I get it. I would be angry too." Not like, "Oh, let's go fucking blow this shit up," but like, "Oh, I'm gonna, rage with you, but, no, I see you," and that makes sense. Your brain is so desperate to hear that because it's like, "Hey, I have a signal and this is upsetting," and you're like, "Hey, I see you enough to name it," and the brain's like, "Oh, thank God I can be quiet now. I can cool it down." So talking about that in therapy is so huge, and, like, they're like, "Does talk therapy work?" And yeah, it does. You get a space to put it, and especially where people who don't wanna talk about the terrible calls with all the details with their spouse, people, right? It's a nice outlet. There's also so many ways to do that so that you stay connected. The people wanna know real life experience. What's going on in your day? What it's not any I don't know about you if you've ever been like, "How was your day?" "It was good." "What did you do?" And it's like, no, like, tell me about how, like, "Oh, I got all green lights going to work today, so I was on time for the first time in 2 weeks. I'm so pumped." And then your partner's like, "Nice, that's awesome. That so important to you because you're late for everything," right? Like, you get more, like, "Oh, no, I had this really rough moment." And if someone's like, "Yeah, tell me about it." "Oh, that does sound rough." It's not that they're fixing it for you, it's already done. It's already happened, but your brain gets the signal of saying like, "Hey, I can put this down now because I got to talk about it with recognition and validation that that was a real feeling in that moment."
Mom, if you're listening, cover your ears. But I actually have been to a therapist in the past, and I'll be honest, I felt a great deal of stigma going in. Um, and to be honest, you had brought up like this idea of professionals wanting to underplay things for various reasons, whether it's holding yourself to a standard. But I will tell you a story that really influenced my take on therapy and all this. I had a colleague in one of my jobs that I've worked in the past who had a little bit of a drinking problem. Like it wasn't like these crazy, like drinking every day DUI, but his wife said his drinking was enough that she wanted him to get help. And so he did. He opened himself up. He made himself vulnerable. And what happens is he was then reported to the state board who then subjected him to what I honestly felt was absolute fucking humiliation. Like the only person who knew what was going on was me. But like, so I understood like he would randomly just disappear from clinic and no one else knew why, but I understood that they were drug testing him randomly. So whatever he had to do, he had to put down everything he had to cancel his patients just to like pee in the cup for some bureaucrat, you know? And he wasn't really like as problem drinkers go, like really like I'm a doctor, I see far worse. And so I like to me, one, there's a natural fear as a medical professional of actually, if I had a problem, seeking help. And one other thing I found, I don't know if you could speak to this in any, but like when for the short period of time where I saw a therapist, I eventually stopped because I felt gross because I felt like I was being like super self-indulgent. I don't know if you ever had anyone express, but like, when I'm complaining about my life, these are like the literal definition of first world problems. Like, I'm healthy, my family's healthy, like I'm dealing with the stresses of normal life. I don't know. Do you come across that like people who feel the same way that they're embarrassed because of that feeling of being like too much like a TikTok person that's talking about their oversharing about their trauma?
Oh, yeah, all the time, and it's the same with, like, it gives me a lot of insight to get around how your mind works, right? Is also the voice that says, like, "This is too much. Oh my gosh, this is petty." It's a judgment, and it's you judging yourself, and then we also externalize that judgment, right? We project it on the situation, and then we deem it a certain way. And I think when, we're going to a place and we're imagining that, "Oh, I'm just gonna complain and leave." No, that doesn't feel good, right? It's about processing, talking about it, getting perspective, also getting tools, also understanding, right? Like we understand, like, oh, there isn't someone who just wins. Like, well, if it was like, well, okay, um, your trauma's pretty bad, but someone else has had it worse. So you actually don't get to complain about that. There would be one first responder with the worst thing, and there's the only one, right? Like trauma one is subjective. So many things happen to us based on our upbringing, based by other things that impact on how we perceive what happens and what sticks with us and what might not stick with someone else. Like that's part of it. Also, um, when we imagine that someone else has it worse, so I don't get to own mine, the only body you live in is yours. You don't live in their body. You don't live in their mind. So if you want to show up the best version of yourself, instead of, I would say, like shitting on yourself about what is bothering you, wouldn't it be nice to clear it up so that you have more room? And then having access to tools that allow you to hold both. Wow, okay, this is bothering me. And I have perspective that there are other things that are bigger. Okay, what do I want to do with that then? Versus like, no, this isn't tolerable and I should only complain and only be upset when leaves that unsettled and it leaves it kind of digested. And that's what I mean when I talk about processing. It's like talking about your feelings, actually naming them. When you don't do it, it's really uncomfortable. You don't have much tolerance for it. And then you just don't really trust it. You show up and you start to do it more. You build that muscle, right? And over time, you're like, wow, I actually get a lot of relief from this. I actually turned dialed down so much. And now it's showing up in my everyday life where the voice in my head is a lot quieter and I've replaced it with these tools and by talking about it and getting things to move through me versus just staying stuck and then just trying to like water it down by what I deem as important or not, which is a viewpoint, not a truth for yourself.
I know you're definitely someone who is a strong believer in therapy. Is that am I
You're
characterized?
you're gonna out me on national podcast network on the Better Life National Podcast Network. Yeah, no, I'm a huge proponent in therapy, but before I was a huge proponent in therapy, I really enjoyed recreationally complaining. And my Jewish friends taught me that there's a Yiddish word for this called kvetching, and it's a hobby. It's just like complaining. And if you're a first responder, you complain about the bullshit you deal with there and the craziest terrible things you do there. If you're in the healthcare field, you kvetch about some of the challenging situations you end up in, and some of the unreasonable requests perhaps you get, or the difficulty of the job. I love kvetching. I really love it. I do need to turn it down sometime. Sometimes it appears as a bit of a downer, a bit of a negative to the people around me, but I love it. And I've told a lot of people, I've promoted therapy to many people, and I've said it's like it's like having a professional friend. Like someone listens to you. They don't always kiss your ass. Sometimes they give you tools. Sometimes they challenge you. Sometimes they ask you, um, do you think do you think Dave, they'll ask you questions like, they'll be like, well, maybe the reason you think it's not okay to complain about that is because your father told you when you were a kid that you should never complain about anything. And maybe that's your inner internalization of your father just telling you that whatever you care about is petty. But like, I don't know, they give you these like perspective shifts, right? Is really what I'm trying to, besides being silly, like I'm trying to, they give you, I like therapy. I'm a proponent. I've probably been to 10 different therapists. I probably liked 3 of them. Um, and that is something that as personally that like that feature of it that like I warn people as I promote therapy, I also encourage people. I'm like, go see more than one person. Like, if you don't click right away, go see another person. Like, try it a couple times because when you find the right therapeutic relationship, it's really awesome to have somebody in your corner and somebody to help you grow. And when you don't, you can overgeneralize and think that like therapy doesn't work.
I love that you talked about, Andrew, around like complaining and whatnot. Like when we, yeah, people love complaining. Who doesn't? Like that's a, yeah. And this idea that talking about feelings or petty or whatnot, I'm not saying like name at all. We have things that roll through us all the time, right? The more we are able to own it, the quicker we get to the part that says like, oh, it's no big deal. Because if we don't, and we try to water it down like I shouldn't be, we don't actually process it. We're not actually moving through that, like, no, but that really like, I don't know, but I can't turn off my spleen. I can't make it on or off, and, like, me having a feeling, like, I
We have a supplement for that. We have a supplement for that. Just for 5 payments of $9.99, this can be
for
yours.
for
Yeah.
like,
our
I
functional spleen supplement.
if I have a feeling in my body, like, not the emotion is the name of it, right? But a feeling, like, if a car slams on its brakes in front of me, I am startled. I can't tell myself, "Oh, you shouldn't have been startled. That shouldn't have bothered you." Like, does that change the fact that I was startled in my body? No. So, if I'm like, "Yeah, I was startled, that makes sense." Guess what? Then I get to everything else a little easier because I had that ownership of like, "Yeah, no, that makes sense. And now what?" Right? It's the same way, like, when we don't give room for those parts, they just kinda turn in our brain that, like, "No, okay, well, the signals will water it down, but it still needs to be processed," but will turn into anger or irritability or judgment real easily, because that's we love to do that, right? The other part you mentioned was, going to so many therapists. Thank goodness you said this because I can never represent the whole field of therapy. Oh my gosh. No, and when people come to me and I'm like, "Look, like I swear a lot. I am sometimes late. I show up as a human. I go to therapy. I'm a huge advocate of it. Like I don't think you can really advocate for the thing that you do if you are also working on yourself. And my ego's checked at the door. If we don't jam, I love that you told me that and I'm in it with you. Let's find someone who does fit you. If you don't want a woman, fantastic, great. Let's find you someone else. But I want to be in your corner until you land with someone that does, because I don't want you to end all be with me. I am a spoke in the wheel. I am not the mental health wheel. And so please, like, let me be a part of that because I don't want people's journey or whatever you want to call it with mental health be stuck because they didn't have a connection with me. And part of me being authentic to that is that I will not bullshit you. If we do not have rapport, I can't fake that. And then a majority of therapy, like if you want to talk to what is the most effective therapy, it's going to have connection and rapport. Like no matter what modality. If you don't trust the person you're working with, if you're as a therapist, you're like, I don't care what the fuck you say. It's going to go out my ear because I don't trust you. So yeah, like
You do that like with certain patients. You do it's not you, it's me. I'm
Well, I
sorry.
tell people, like,
Have a
well, I will say
relationship.
yes, like, I've been like, "Hey, you know what? The area of your focus is outside the ethical scope of my capacity and capability."
Whoa, whoa. The area of your focus is outside the ethical scope of my capability.
Yeah.
Wow. Okay, that's a mouthful. That's gonna be our short. That's somehow that's gonna be the short. I don't know. We'll see how the engagement goes on that one.
But it is true, like, if someone comes in there, and they have borderline personality disorder, I don't work with borderlines. It's not an area that I have a lot of expertise in, and it's not something that I can tend to, over my own experience, have build authentic rapport. And that's not to say I won't, but I will be very upfront about it.
It's funny that you say that about borderlines because we literally just dropped a podcast that came out today. It was published today on specifically on cluster B personality disorders. The focus was on narcissism, uh, but
And this book,
yeah,
so
please don't.
surrounded by narcissists.
Yeah,
Yeah.
I didn't want. I didn't love this book. I don't want to necessarily get more sales as a result of this. So, mom, don't buy this book. But in all seriousness,
Dave, you're in it. You're in it on page 7, page 17, page 42.
it's funny that you say that about borderlines in particular, because one of the things I mentioned is like borderline is the kind of diagnosis that even though we as predominantly medical doctors, we certainly don't diagnose because it's quite a damning diagnosis to have in a lot of ways. But we feel like we know it, like it's the patient that tells you, basically you're the greatest thing since sliced bread, and their last doctor was terrible in all these ways. And we know in 3 months we're going to be the one that's under scrutiny, and there'll be another doctor hearing this story. So like it's one of those things that like, do you diagnose personality disorders? Do they come in with that diagnosis, or like how does that discussion even happen?
A mixed bag. Some people say, "Hey, I was diagnosed with this." And I'm like, "Cool, I wanna also do an assessment because I don't wanna blindly or have, an ROI for your previous therapist or where you got your diagnosis." And interestingly, I wanna work with the person, right? And I think we get caught up in diagnosis, and then we get stuck there, and people also get stuck there. It's like, "Well, I am this." And a lot of that time is, like, that limits their perception of their ability to move through it or work with it, and it's just kind of this blanketed, uh, title, this blanketed identity, and so, with insurance, I diagnose because I have to, and if someone prefers me to and for it to be a part of it, then I will, but more so I wanna, I don't tend to diagnose uh, in my own practice, my private practice.
It's funny. This actually brings me. It's funny. I was so excited to talk to you today, Al, that I prepared a list of all these questions, and I've literally not a single.
We've mapped out the next 5 hours of
Yeah, you'll just
conversation
have
with
to
you.
have me on
So
again, guys.
yeah, yeah,
Exactly.
yeah.
But one of the reasons you, I kind of brought you on was this concern, like, are we overdiagnosing things? Like, so one of the things, like, for example, I have a patient that whose therapist told them they had borderline personality. I've worked with this patient for years. I mean, I could see some elements that maybe point to it, but they certainly don't give off that vibe. And I told them, I was like, I would really be sure about this diagnosis because it has a lot of stigma and a lot of like implications. Because as you know, the classic teaching is you can't, there's no therapy for them. But as this relates to trauma, there's been like kind of this growing shift in the definition of trauma that has been really popularized by jerks like me in in the social media realm and all that stuff. you
And
know
and
wh-
and hip movies like Bad Bosses and
yeah, we're talking about trauma like things like trauma from having a boss that micromanaged them, or generational trauma, or
or someone that uses the wrong pronouns, or
yeah, or, not to minimize that much, but like somebody who says, I had trauma from my upbringing, but it wasn't like abusive in the classical sense. Do you think that this is like this kind of creeping of the definition of trauma to include more things is what we need in terms of recognizing and treating PTSD, or do you think that it's leading us to overdiagnose?
I think our vernacular does not hold enough words for really horrible moments. And we latch on and overutilize trauma because we want to show the impact of something. And so we use these really aggressive, large, like traumatic is a tragedy, right? It is experiencing as something that is out of the norm in how the bandwidth in which you experience your everyday, your brain does not have capacity to hold it. And so now it is now stuck in either hypervigilance or has maladaptive cognitions, avoidance, nightmares. Like that is traumatic, right? But we don't have we don't use words because we really people tend to use trauma is that they really want to convey how something impacted them deeply or was awful. And their concern is that you're not gonna get it unless they go to, DEFCON 5 with the big with the
and
big
unless they use hyperbole and call it
exactly.
trauma.
And
Yeah.
so I think we need more words that accurately articulate pain. I can also sit with someone who has been on a terrible call and is describing something horrible that they saw, and then the next person I see is talking about how they lost a pet. And I can hold space for both being out of the parameters and being traumatic depending on the thing, right? I more so I think if we get stuck in the name or the diagnosis, as you mentioned, we miss this idea that um, you know, trauma in general, our human brains are primarily wired to process trauma. Like 80% of the things that might they're gonna our brain will given time, we go through acute stress disorder, we go through the normal things, just like if you hurt your knee, if you fell and you really hurt your knee, you would have no expectation that you should behave as if you didn't just hurt your knee. You'd be like, "No, this hurts and I can't walk on it the same." You wouldn't be like, "Oh, no, I should just run it off and act like it didn't happen." And then, right? Like your brain experienced something that doesn't fit in the norm of how you operate. And now it needs time to move through that. And whether that is if you're willing to talk about it, feel it in the right way, talk about it in the right way, and think about it in the right way, your brain actually does what it's meant to do. There are, of course, traumas that exist that are, given the amount of time, they're just too large, right? And you need help with that, or we have that understanding that it's a piece of you might not be able to be put back the way you were before. But we can do a lot to help get what we can there. But we have that understanding that trauma can impact you. I think the overuse, I try to give other people language like, God, that was really impactful. It's really sticking with you. It's still with you today. Where would you like it to be? Would you like it to be a memory that now becomes like a bad boss that annoyed you, right? Are you still thinking about that? Let's talk about that. Like, what is sitting with you? And that's a deeper thing. That's not trauma. And I'm not going to latch onto that or judge them for it. I'm just going to offer them alternatives that might accurately give them the words.
You're giving them vernacular to express their own feelings. Uh, but I actually want to focus on words, and I apologize that this is going to be the boring part. But Andrew, do you mind chucking up the DSM 5 criteria for diagnosing PTSD on the screen? Because specifically, it's a long, extensive criteria where you have to meet a lot of conditions. I don't want to go over all of it because that's going to be boring. But I really want to focus on a couple key elements, particularly in the first criterion. According to the DSM, in order to have, uh, the criteria for PTSD, you have to have exposure to an actual or threatened death, serious injury, or sexual violence expressed in one or more of the following ways. And that can be directly experiencing a traumatic event, witnessing that happened to someone else, learning that it occurred to a family member. That kind of those are kind of. But the idea is that in order to meet the PTSD criteria, there has to be some threat of extreme violence or sexual assault to you or a loved one. Do you feel that's too narrow of a definition? Do you go by this DSM criteria in making your assessment of some whether or not someone truly has PTSD?
I do actually, yeah. And I don't think it's too narrow. I think we have different types of trauma, that don't necessarily have a DSM category, like secondary trauma or vicarious trauma. We also have the realm of what people still consider of like compassion fatigue and all these other things that happen, burnout that people put into that category more than I would like to say. But when it comes to PTSD, yes, I absolutely use this, and I don't think it's too narrow. No.
That must mean that there's many patients, whether they're your patients or just patients that exist generally, that are experiencing something quite similar to textbook definition PTSD, but it may have come at the constant beratement of a boss in a professional scenario that wasn't threats of death or threats of violence. It- there must be people who experience chronic abuse, I guess is kind of what I'm getting at, like who have some similar mechanisms that they need to process that are similar to PTSD.
You're looking at the symptoms, right? You're looking at the outcome, um, and at that point, and I work with individuals who experience witnessing really horrible things, and then what that lands them with, if it doesn't go through just the normal acute stress, and then secondary trauma, which is, we give it a time if you're to move through. If you're still having avoidance of hypervigilance, if you're still having maladaptive cognitions, nightmares, um, if your body's responding still as if you're in the moment, yeah, like that's what I see the most of. So this definition for my clientele is pretty easy to see. And the problem with it is that it's very specific, and I have a lot of individuals who aren't getting help for it. It's like they do have PTSD, and yet the stigma or the idea that they shouldn't, or that they're helper and they shouldn't be hurt, or that they weren't involved in this stuff, and then their life gets really small because they're trying to self insulate them from the thing versus move.
Can we incentivize them to seek identification and diagnosis? Like, can we give them bath salts or lollipops or pats on the back or trophies or something? I mean,
I would love that. If that works, man, I would give out lollipops and trophies.
high fives. Yeah, yeah. I mean, there has been a trend. There has been a trend in pop culture um to put people on a pedestal based on how much of a victim they are, right? So there's, I suspect this hasn't bled over into the first responder community. There hasn't been this kind of competitive aspect of people wanting to show that they're more messed up than other people and that they need more therapy than someone else. But that it's kind of a cultural phenomena that I don't generally support, but perhaps if it led to people getting more therapy that they needed, perhaps that could be a good thing.
Yeah, that's definitely not something I encounter.
There's no competitive victimhood.
I did want to bring up that both you guys do have white privilege, and I
Right.
Washington.
And we're recording this on stolen land.
That's what I
So
was hoping I'll do land acknowledgement, but she failed that test. But in all seriousness, you talk about because the rest of the criteria are largely symptoms, right? So let's talk about this because I used to see this all the time. Like I used to do primary care for Disney. I would see people with PTSD diagnoses. I don't know where they got them from, but when I asked them what the trigger was, it was something like like a malignant work situation that wasn't, physically or sexually threatening, yet they have the manifestations. Like if they try to go to work, they have the avoidance kind of, that symptom where they get uncomfortable physically. They start having sweats and racing heart. And, so oftentimes they're asking for some kind of accommodation or whatever. So if we're taking that at face value, do you feel it's kind of arbitrary defining like PTSD solely from the lens of like this specific definition of threat of grievous harm?
I think coming from the symptoms specifically, but not having that, I would have a lot of curiosity. I would have a lot more questions to ask, and I'd wanna know a lot more, and I'd be curious around, you know, phobias of other diagnoses, uh, right? That if there isn't a moment in time, like, the whole point of not point, but the huge part of it is, like, it feels like a timestamp, like a moment in time that is embedded in your brain. And if the moment in time is not feeling objectively, right, able to quantify into a PTSD actual criteria, I would have a lot of questions. I wouldn't at all negate their symptoms, but I certainly don't know, right? Like I would want us to.
Hearing is there probably should be a definable moment like you remember Wednesday, February 17th of 2020, my boss yelled at me and like punched the wall right next to me and I was terrified. And from that moment, I versus like, yeah, like I had a girlfriend who absolutely sought to every day was browbeating me and like telling
We're
me
champions of women on this podcast, Dave. I think you're telling the wrong story.
Yes. Yeah.
that's less convincing to you because it's not like there's one moment, where the girlfriend brandished a knife and threatened him kind of thing.
Yes, for diagnosis of PTSD, I would yes. And I would wanna know there if it wasn't that, it would be something deeper, right? And that was the surface level, it kinda becomes whack-a-mole. It's like this is the thing, and versus, like, there's clearly something else, and maybe it is child abuse when you were younger, maybe it is something, and this is what's touching it now. It's kinda like the straw that broke the camel's back, and so that's what we're really focused on and seeing, and then we're like, "That's not PTSD," but really, it could be like, "Oh, yeah, and actually it translates to this," and we do the whole work to get down to that. So,
Yeah. Like
does that
maybe as a child, your mom left you in a crib alone for a week while she like went off on a cruise or something with like, her friends. Like you hear stories like this, right? And maybe that is where this sort of difficulty with relationships comes from, is what you're saying. Like it could be
Yes.
back to
Where you're like,
earth.
"Oh, I saw a crib and it upset me," and you're like, "That isn't the thing." But it is the surface level of hitting something else, and especially with, childhood trauma, your brain is this magnificent thing that puts up a lot of things where you can't remember, and all of a sudden, have you read the book Body Keeps Score?
Yes, by Dr. Van something.
And Vesselvik?
Yes, something like that.
So the
That
and
name.
it's how, like, you might remember and your body will show up with a thing, and then you show up with the symptoms and you talk to someone just with that, and they're like, "This doesn't make sense." And you might not have the actual memory to be like, "Well, it's because of this that I was traumatized in." And so, yeah, it can look across like, "Oh, you're not this isn't PTSD," right? But really it's your brain doing what it needs to do to protect you, and then actually we need to deal with it.
It's funny, in his book, he actually looks at fMRI slides where, like, when someone is recounting a traumatic experience, basically all of the higher processing parts of the brain are just like shut down. And the primitive lizard brain, the amygdala, and all that is just on fire. And it's interesting that he kind of talks about that as like the mechanism. That is that fight or flight mechanism where your rational mind basically stops functioning and your primitive fight or flight mind comes on. And that does kind of eloquently explain, like, the symptoms of PTSD, the flashbacks, the nightmares, the avoidance, and all that kind of stuff. But I actually, this brings me to two really important questions. It's a two-parter. Um, One, whenever I see the diagnosis of PTSD, I always question how did they get it. So my question for you is, what? Because it's an extensive criteria, and you have to exclude a lot of things. Like, realistically, for someone to get a proper diagnosis, how much time should be spent with that patient and evaluating them to really give them this diagnosis? Like, how much time does it take you? And then the follow-up question is, do you think this is something that's being overdiagnosed?
I have measures that I have people fill out that and multiple. So if it's hitting multiple, uh, the let's see, PSI, all of the oh my gosh, my brain. I just send them out. I send so many out,
So
but I
these are diagnostic quizzes sorts of
yeah,
things. Yeah,
yeah,
yeah.
assessments, and then I have personal assessments where they fill out, and all as well as the ACE scored, like, child, and I will
And
have
then you have Chat GPT review all the responses.
yeah, but depending on their score, I don't negate anything that comes up. I always address it, and, it if I don't, in my again, I don't get people who lie about it, so I don't know. I don't maybe have the best.
Gauge on that?
Yeah, because that's not something I encounter. Usually it's that they try to downplay something so serious because they don't want it to be that, although they fit every criteria.
The reason I find this question fascinating is I also work in the ADHD space, which is one of these really controversial spaces because the mainstay of treatment is a controlled medication. It's your stimulants, amphetamine, or something close to, right? And so when I went in this space, uh, I was super careful to not be the done first in the cerebrals of, the world where they are taking a 10-minute quiz and just popping a diagnosis. I see so much of that in our own practice. We have extensive, like you do, we have our own proprietary questionnaire that we have them fill out. And we do other kind of questionnaires to look for other conditions. And, I spend minimum 90 minutes with them in the initial assessment. The nervousness I always had was, slapping on a diagnosis being part of what I really see as the problem in medicine, where it's this rapid, quick diagnosis, quick solution. I don't know. I don't know. I'm sure if you look at all in the greater world of PTSD, but I can tell you from the medicine world where we filter everything, I see a ton of questionable diagnoses. I wonder if it's overdiagnosed, and especially if there was ever a treatment that had this potential recreational or financial gain to it. I wonder if that's something that would concern you.
Yeah, of course. I mean, I think um, I will say that those that are probably in the industry of working with PTSD, have that experience to some degree, even if it gets louder in society and pub media and whatnot, they still have the ability to, uh, know their expertise, just like I'm sure you have ability to dial down the noise and navigate people who really do have ADHD versus not. And if anything, it's an opportunity to fine tune your capacity to do that, which is kind of what I would say I take that on as well with it, assessments or being longer or looking for questions, measurements that are very accurate, and making sure that you assess for those.
So what I find is it's not so black and white. In the world of ADHD, what I find is this. So classically, we're taught in ADHD, just like with PTSD, it's like there's a list of symptoms they have to have, and they can't have other coexisting problems that might explain it. So traditionally, what we're kind of taught as doctors is like someone comes in with depression and anxiety and ADHD. you treat the depression, anxiety first. Um, you know, what I find is quite the opposite in reality. Oftentimes, once you treat the ADHD, it all these things go away. And I sometimes find some people that may not exactly meet criteria based on DSM for ADHD, but they have a lot of the symptoms. They have a lot of depression, anxiety, and I'm willing to give those patients a trial because they failed, antidepressants and therapy and all that. And sometimes this is like it's a godsend, like it like changes their whole life, So one hand, I'm open to the idea of broadening our horizons of like what defines a mental illness, what defines trauma, what defines ADHD, which is obviously more complex in our modern world. But at the same time, yeah, just like we've seen an explosion in ADHD cases since the advent of telehealth and things like that. I wonder sometimes if we're seeing an explosion of PTSD diagnoses.
It's going to sound maybe not good, but I would like there to be I know, I would like there to be more diagnosis of PTSD in first responders and medical professionals with high stress jobs because I it very much correlates that way. It makes so much sense. So having that means that they're getting treatment and they're getting proper care. And it being more publicly known is just that it's less living in silence. And I think the more we imagine that because it's publicly known, more people are abusing that is giving people way less, I don't too much credit. And I think the people who really wanna use a stimulant for the wrong purposes are going to find a way. Do I think that's the majority? No, I think, people who really need it might actually get care, just like how I imagine with PTSD. So that's the whole point is to get care, and I also appreciate what you said is that you monitor it, you try it, you test it. It's not a well, this is it or this is not. And or I believe you or I don't. It's a like, you know what? I have room for me to know that I might get it wrong with this and let's get room to try it out. And I think that is the sign of someone who's dedicated to what they're doing and sees the person, not just the diagnosis. And that's what I would hope for my own doctor as well as my own therapist, right? Is like, hey, here's also a treatment. And if this works, this works. Great. If not, then cool. I don't need the diagnosis, right? I need the parameters to know what we're treating. And if this is the symptom and these are the things, then I want to see you as the person, not just get stuck in the diagnosis and the criteria of like best treatment.
So what I'm hearing is the increased awareness of this sort of underdiagnosed in the populations that really need it that is counterweighs like the annoying like TikTok trend of people talking about how they were traumatized by their ex-boyfriend or girlfriend in something that may not really meet criteria. Like in the end, the awareness is a net positive, even if it may have some negative externalities.
People using the word trauma to describe things that aren't traumatic is fucking annoying. Yeah. Like it doesn't like that's the truth. People
that's
Right?
we've
Like,
been trying to get
people
you to say that for an
overuse
hour.
in
Yeah, yeah, yeah.
media the word trigger all the time. I was triggered, and for me as a trauma therapist, I'm like, "Ugh," I shudder, and I don't even use that word anymore, not because it's not accurate, but it's because it's so overused. It's same with, like, self-care, and when I see it feels so like, "Ugh," like, what does that mean? And, like, we hear it so much that it loses its actual it's so watered down now, or it's overplayed, and it's over meant to be something that it actually loses its meaning, and I think, like, that's annoying, but that's not impacting me as a therapist. I'm not every person on TikTok who said they're traumatized is reaching out for therapy, right? Like that's still living in TikTok and I'm like, that's annoying, but it's not
They just want likes, subscribes, and comments. Come on.
right, exactly. Like, okay, whatever that's what that is. But that's not if they're going to therapy for that, like we're gonna talk about that with a lot of curiosity.
As long as they're seeing a licensed clinical therapist, yes. Um, we have to end soon, but I have 2 questions I can't withhold. So if you'll permit me, one is if you see a patient who meets clinical criteria of having a particular disorder, and if through therapy they no longer meet those criteria, are they cured?
Are they cured of their PTSD?
Yeah, right. So if I meet criteria for PTSD, but then through therapy, I no longer meet criteria for PTSD, am I cured of PTSD? Do we say this is a curable disorder?
Yeah, absolutely. I mean, we like we I prefer the definition of post-traumatic injury, knowing that your brain is not supposed to have capacity for something it's not supposed to, and then it gets stuck there. Similarly, if um, trip over a rock and break your leg somehow and don't get
If you
it
don't set it with a splint and let it heal
you
correctly,
can
yeah.
move through life, but now you have a limp, right? And then you go to the doctor and you do the painful thing that hurts a lot to get it set, to get it and it takes you out of your job and do all the thing, but then you're well, right? And what we want is post-traumatic growth, which is that the thing that happened is gonna get you not only through the injury, but what it's the meaning of it and how it translates to how you identify moving forward. And there are people who have trauma that cannot be, losing your own child, having seen something that you there are things that your brain cannot fully heal from, and it's not supposed to because it is so painful, and uh I would say 1, not on its own, it's very unlikely, and 2, maybe not ever, right? I know that there are things if you imagine, like, if that happened to me, I don't know if I would be okay after that. Similarly, like, people have injuries where they're like, "No, and I still walk with a limp because of that thing, even though I went to PT, even though I did all the things, right? And that's because the injury was so big, and that's the same with PTSD. We don't have that expectation, though. We don't wanna keep people from getting help, though, when they know that, like, "No, this can be better." And, if it can't be best, we can get it at least as close as we can so that you don't have to live with so much suffering.
So we see in broadly, across our world in the United States here, kind of this proliferation of diagnosis. PTSD is one of many conditions that is kind of on the rise in terms of its awareness and recognition. Um, there's this like curmudgeon in me that is tempted to believe that this is actually the result of like our civilization, our society kind of failing to help people talk about things and process things and we're going to continue to see a rise in these mental health conditions and many others for as long as we continue to have a society that doesn't practice good good handling of grief or good handling of frustration or
Bring a counterpoint that was a question that was on our list that I think this leads really.
oh, you and the questions.
So you're mentioning, perhaps we need a society that is more accepting, more tolerant, more open to therapy and recognizing trauma. But one example that people bring up all the time is the London Blitz. I don't know if you've ever heard this example about trauma responses. Are you familiar with like that?
First of all, what were you doing in 1941? Are you familiar with the London Blitz?
Yeah, so the London Blitz obviously occurred
So
during.
the Germans were bombing the hell out of London.
Yeah,
It
so they
was a
were bombing
scary time to live in London.
London. People, this is where the famous "keep calm and carry on" comes from, right? And so one of the things that this is always um, heralded as an example of extreme traumatic events, meaning bombings where there's literally life threatened, yet very low percentages of like what they had a different term for it now, but what would now be called PTSD, and people generally recovering from symptoms fast. So and that kind of points to, people point to it being, oh, it was the social cohesion. Everyone was in this together because it was us versus the Germans, and that's what freed people. But it's interesting because at the time like that, there was not really any acceptance. I think the best term they had for it was like, wartime neuroses or shell shock or whatever. Yet people seem to be recovering quite well. So is there something to be learned from there? Like perhaps we need more social cohesion. Perhaps we need to keep calm and carry on and have a stiff upper lip. I don't know. What are your thoughts like? And by the way, this is a contested view of history. Some people say that that's not the case, but That's the myth. So hearing that myth, what is your thought?
Yeah, I would be really careful to use something a measurement of 1940s war as an indicator of what we should be doing today with mental health. I feel like there was probably a lot of reasons why, you know, there are a lot of things we didn't know then and, underreported, undershared, like, there's so many things there, but I understand what you're saying, right? Is like, and it is something that I do think is worth mentioning. First responders in paramilitary culture have highest suicide rate um, in any industry in the United States, and that is they also have higher rates of PTSD, and that includes the military. You can find the statistics on this somewhere. But the reason that is the stigma around it is still quite large, in paramilitary and the military, yes, but it also has a lot more resources and people are getting them. The other part is, yes, belonging is a huge piece to getting treatment, to getting support, and also co-regulation, people going through it together and moving through and not feeling othered is a way that people actually move through trauma and process it together. It's also why departments have defuses or debriefs after a really traumatic call. They get together and there's something there that they process and move through. That is not the cure for trauma, but it has been shown to help not only align the full story, and so maladaptive cognitions have less opportunity, but it also is about coming together and people owning the stuff that is traumatic, allows people to move through it versus saying, what happens is like anyone struggling after that call, and it's like, no, I'm good. Okay, everyone else, okay, I guess I'm good too, even though like I'm really struggling, right? Um, and so having those spaces where people are able to own allows them to move through it. So I do think there is something to the group part, and I do believe there is also something to the space of having resources and tools available.
So I think like firefighters, in my view, they tend to have quite a bit of pro-social cohesion, right? Like they like people within the school. And correct me if I'm wrong, but I tend to feel like they do have like sort of deep bonds. Like it is almost like the way I've heard it described, almost like a clubhouse. They meet together and they work out together. They do jujitsu together. You know, do you think, like, because like, on one hand, I would think that that would actually help them through a lot of the trauma, but on the other hand, you're telling me they have really high rates of suicide. So perhaps that social cohesion isn't doing, the trick. I don't know.
We all want to belong. We want a sense of belonging. It's what makes a lot of departments really attractive, right? Is that sense of brotherhood or sisterhood, all of that. That is the family identity, and yet um, that is not an invitation for like, oh, we struggle together. Right? There's a big difference there, and the more stigma there is that mental health is not something that shows how strong you are, but actually shows how weak you are in an industry in which you're supposed to be someone who helps others, that implies strength. And so you are not going to be someone who comes into that space wanting to belong, wanting to be strong, to be helpful, to be good at your job, and then also imagining that you could also be someone who is struggling, very much so. Yeah. And so the goal is to say, like, just like you mentioned earlier, like, what do we give people to go to therapy, right? Like, the hope is that it's, "Oh my god, I no longer am dealing with this." Like, that's what we
Hmm.
want. We wanna sell the, like,
Relief,
and then you can move
relief. Yeah.
on, right? Like, when I said I don't think everyone needs therapy, but I want people to go and then they don't need to stay in it. You go, you leave. Or you have a therapist who aligns with you for part of the time and you try 8 others because you're like, "Okay, that one didn't work and then this one worked in this part of my life and now I don't need anyone for this one." And that's a way to approach it, right? Is that we want people to get the help that they need so that they can not only just do the job for as long as they want it to the best of their capacity, but also be the person they want while living a really stressful, painful job at times.
So yeah, well, what I'm hearing is social cohesion is part of it, but without like this openness to be able to share in our struggles, which is oftentimes facilitated by therapists such as yourself, it's not enough, right? Like it's not enough just to have your boys in the fire department who have all been through this, if they don't talk about it. Uh,
But
yeah,
if they did talk about it, it might be enough for some of them. And it would be good if they did talk about it.
Absolutely, and enough for people to say like, "Wow, I can it's comfortable I look up to that person and they're admitting they're struggling," and I think no less of them, and actually now that they were able to struggle and move through it, that gives me, confidence to know that how people might judge me because we don't wanna be judged is, is maybe not as big as I deem that it would be if I was to share how much pain I'm in.
Gotta let everyone go soon.
one last question. I'm so
Okay, Dave, last question. You get 2 minutes.
My
Go.
last question. I know you're a good therapist. We'll link your web page in this.
ElleMillerTherapy.com. Yes.
But the last question I had for you is, as a doctor, one of the hardest things for me to do is when a patient needs therapy is find a therapist. How do you find a good therapist? If you're a consumer and you want to find a therapist, the market seems to be saturated. As Andrew said, he had to go through multiples. How do you find a good therapist, or is it just simply trial and error?
That's such a great question, and I wish I had a really direct answer. I think there, I would say, like, how do you find a good doctor, right? Like, you often have to try people out, and then you have parameters of insurance, of pay, um, of, economic capacity for it. Like, there's so many things that play out. A lot of people need therapy and then don't have, the financial means for it, and that's awful, right? Or need therapy, need it to be in their insurance, and they don't have good providers or people who have openings. Right now, most therapists, like, are a lot do not have openings because,
They have a full
there's
panel.
such a big need, right? And
Yeah.
especially the one that's gonna align with you. You wanna keep going, and, when you're struggling is when you start to look, and it's kinda like, I would say if you can establish and have the bandwidth to have patience to try invest, not when you're struggling, but when you're actually feeling okay, so that you can make a connection, you can have someone in your pocket, not as a like, "Oh, I'm gonna see you every week and I have to keep you that way," but if that is the case of like, "Can I establish care with you? Can I meet with you? I have some things that I'd like to work on, and then can I have it," and having someone who might be able to see you once a month, every 2 months, but then you have that relationship, or at least when you have bandwidth to meet and talk with people and be like, "Okay, well, when I am struggling, I really liked her. A 10-minute free consult is what most therapists offer, and I do think I'll go back to her," right? Or him. And I would say psychology today is a great way to start reaching out to your friends who you connect to, who are open about going to therapy, and be like, What was your process? Do you recommend? Does your therapist have someone that they recommend?" Um, right? As well as like if you're looking for a child therapist, go looking at the hospital websites, looking at your school district websites. If you're looking for a couples therapist, hopefully, talking to, if you have a friend of a friend who's a therapist, you recommend, like, just I think referrals, and then Psych Today, and looking at, bios of people who interest you, and then doing a 10-minute, free consult.
So yeah, so go out and get that 10-minute free consult. Sorry. Oh my God. I'm so
Speed
excited on
dating.
this.
Speed dating for therapists.
Yes or
Uh,
no? I've heard him admit that if you want to get a good therapist, the best are the ones who only accept cash. Your practice is largely cash based. I know you take some select insurances, but is there any truth to that, or is that all just a myth that I've believed in, like many others?
So I take insurance, and the first responders I see all have Regents. So
Regents of Washington. Yep.
yeah. So, other departments who don't have that, they, can do out of network, but the majority of people I see actually, I take their insurance.
I'm so sorry. Now I feel
That's
like
okay. No, no, no. And a lot of people don't because it is such a lot of really good therapists don't, because it can feel like a scam for what you're getting. paid in return, right? So,
Yeah, we've
but I don't
noticed
think that that
on the medical
necessarily
end.
I
Yeah.
wouldn't qualify myself as a bad therapist and that I take insurance. I don't think that that's necessarily aligned. I do think that when you are new to the interest industry and you're like, "Okay, I need more people," you might get people who are less seasoned, who also who are taking more insurance because they want more people.
Yeah, like, and I want to emphasize the reason that you take largely insurance is that you have a select population that largely has that insurance, so it's reliable,
Yeah,
pay.
no, and no therapist is for the money. We know this, right? Like that's not the thing. It's not the so, yeah, I take insurance because I also really, really am passionate about helping the people that need care and getting care. If financial means is a hindrance, I want to alleviate that as much as I can.
Elle, we've mentioned your website, ellmiller.com, ellmillertherapy.com, pardon me. Um, you mentioned Psychology Today as a useful resource. Is there a TikTok, a YouTube, a Twitter, any sort of feed you want to direct people towards, or a book you'd like to recommend that people check out?
I'm pretty swamped. So I don't do TikTok, I don't do social media, and I love that there's actually more therapists on there, and I think that, someone wrote like, "Oh, why are therapists now on social media?" And it's because a lot of people on social media are trying to be therapists, and I love that.
Mm,
I am all for it, all
correcting a lot of the misinformation out there. Yeah.
yeah. I'm all it's just not mine that I have bandwidth and time for because my schedule just doesn't have it. So I'm just my website and that's it, how people get a hold of me or
Thank
psychology.
you. Thank you. Thank you. Thank you. Thank you so much for joining us. Really appreciate having you and really hope we get to chat more in the future.
Yeah, thanks for having me, guys.
Enjoy the bright sunny day. We don't get a lot of them in the Pacific Northwest in April, but it's like a week full of them. So enjoy them.
Thanks for tuning in to another episode of the After Hours Clinic podcast. Make sure to subscribe to the show on your favorite podcast platform so you never miss an episode. And if you love the show, leave us a review. You can sign up for our newsletter at joinbetterlife.com. And feel free to send in your hot takes and medical questions to podcast@joinbetterlife.com. Disclaimer: this podcast is for informational purposes only and does not constitute medical advice or establish a doctor-patient relationship. Content should not replace professional medical consultation. Always consult your healthcare provider for medical conditions. Do not disregard or delay seeking professional advice based on podcast content.